Good morning, students. I welcome you all for this yet another pathology session. Me here, Dr. Rajesh Patil. Welcome you all. So, students, today we'll be dealing with the topic gallbladder. So, part of the hepatobiliary system here. So, we move on to another important organ, the gallbladder. So, this is an organ that is present just beneath the liver, and without gallbladder also humans can survive. So this is actually a reservoir organ, you can say, which temporarily stores the bile which has been secreted by the liver. So in this heading we shall be today dealing with the acute cholecystitis and chronic cholecystitis, the important topics that can be asked for you in your exams from the exam point of view. And when it comes to clinical point of view, a patient can have this cholecystitis pain, especially in cases of cholelithiasis. Okay, so we'll be dealing important topics here under this is cholecystitis, the acute chronic, and then cholelithiasis, the types of gallstones. So to begin with, so before we go into the subject proper, we'll have a brief introduction into this particular organ. So gallbladder, you can see there, this is just a pear-shaped organ just beneath the liver and near the second part of the duodenum and then near the drainage of these pancreatic secretions. So in vertebrates, the gallbladder, the cholecyst, is a small organ where bile is stored before it is released into the small intestine. So look there, humans can live without even a gallbladder. So it's a pear-shaped reservoir of bile situated in a fossa on the inferior surface of the right lobe of the liver. The fossa for the gallbladder extends from the right end of the porta hepatis to the inferior border of the liver. Exact location, right hypochondriac region. So this first year anatomy, just to fresh you up. Epigastric region on the inferior surface of the liver between quadrate and the right lobe. So basically this is 7 to 10 centimeters long, 3 centimeters broad at its widest part, and about 30 to 50 ml in capacity. So that's the quantity of bile that it can store. So what are the basic parts? Neck, body, fundus. So that's a schematic diagram there depicting the fundal part, body part, the neck part, and then the drainage with this particular cystic duct there joining with that particular common hepatic duct to form a common bile duct, and then joining the pancreatic duct. So this is how it gets secreted and channelized into the small intestine. So neck narrowest part, body main dilated portion that lies between the fundus and the cystic duct. Fundus the bottom that protrudes from under the liver. So biliary apparatus. The biliary apparatus collects bile from the liver, stores it in the gallbladder and transmits it to the second part of the duodenum. So always remember, the second part of the duodenum is always very important anatomically and physiologically, wherein all the secretions are dumped into the small intestine at this juncture. The apparatus consists of the right and the left hepatic ducts, the common hepatic duct, the gallbladder, the cystic duct, the bile duct. So all these contribute the biliary apparatus. Okay, a 3 marks question for you. See here, basically how they get drained, the bile juice. Cystic duct, right hepatic duct, common hepatic duct joining to form common bile duct, and wherein along with the pancreatic duct there is opening in the second part of the duodenum. So this is the wall of the duodenum, cut section there. So how these particular pancreatic duct and the common bile duct join here to open into the hepatopancreatic ampulla of Vater. So the sphincter pancreaticus, sphincter papillae, all these ones. So now yet another diagram there. Sphincter of OD, through which all these secretions are dumped into the second part of the duodenum, the small intestine. Okay. So this is very important, sphincter of OD, when it comes to the digestive enzymes being secreted there and pumped into the small intestine. Ducts again there, right, left hepatic duct, common hepatic duct, common bile ducts. Again 4 parts. So that's a flash on the normal structure there. The diagrammatic representation which you also already dealt with. Another common schematic diagram of the ducts. Physiology, function, basic function, reservoir for bile, concentration, mucus secretion. Okay. So now bile, this is secreted from the hepatocytes. So function, secretion is done by the hepatocytes, and transiently, so it moves into the small intestine via the gallbladder. So gallbladder acts as a reservoir, temporary reservoir. So the normal pH 7 of the bile. So neither acidic nor basic. Secretion half to 1 liter per day. So always remember that. Okay, moving on to our subject proper. Cholecystitis. So in this again we deal with the acute cholecystitis and the chronic cholecystitis. So as the name itself indicates, this is basically the inflammation of the gallbladder. The inflammatory condition of the gallbladder is called as cholecystitis. See that inflamed gallbladder schematic diagram. Commonly due to gallstones, the swollen mucosa. So this is basically a pear-shaped organ. Acute cholecystitis. So acute bacterial inflammation of the gallbladder with or without stone. So types: calculus, acalculous, acute emphysematous cholecystitis. So important ones: calculus, acalculous. So what happens in calculus? The commonly involved one, very 90%. It contributes for the 90%. It is the obstructive cholecystitis due to gallstones, having the most common variety, in which around 90% of people having gallstones suffer. Acalculous, it is non-obstructive type, which is common in persons suffering from major illness like severe sepsis, burns, diabetes, dehydration, multiple injury, etc. So this is basically the non-obstructive types. And then the emphysematous cholecystitis. Bacteriology. Majority of cases of calculus cholecystitis are due to organisms such as E. coli, Streptococcus, Salmonella, Klebsiella. So all these organisms, gram positive, gram negative, contributing for the cholecystitis. So in typhoid fever around second week, so it can be seen that typhoid cholecystitis. So even clostridial infection presents with toxemia. So pathogenesis, that's a flow chart there. The stone outlet obstruction causing stasis of this bile, leading to bacterial proliferation, leading to necrosis and perforation. Another one, mucosal erosion, destruction of cells by toxic bile salts. Now coming to the pathology, what happens basically in the cholecystitis? There is inflammation, perforation, obstruction, and finally the gangrene formation. So basically this is the pathology that's involved in this particular entity, the inflammation. Clinical features, the symptoms, the 4 F's commonly invariably asked question even in your medicine department or in pathology, microbiology, or most of the departments, surgery department, commonly asked viva question, what are the 4 F's? So your answer should be that's seen, that's contributing factors for cholecystitis. 1F, fatty, fertile, female, 40 or 50 age groups. That is the 4 F's that you can see in cholecystitis. It represents as colicky pain and more prolonged due to inflammation. nausea and vomiting. So initially there will be low grade fever. So these are the symptoms that you can come across here. So there could be jaundice, nausea, anorexia, fat intolerance, feeling of fullness, abdominal distension, all this. Okay. So remember 4 F's. Okay. A potential 3 marks question 2. Signs. So more importance, more of clinical examination here. More expressed in surgery department. The Murphy sign. Keep the fingers in right hypochondrium and the patient is told to take deep breath. At height of inspiration, there is sudden catch of breath. Why? It's due to inflamed gallbladder coming in contact with the abdominal wall. This is called as Murphy's sign positive. So what is Boas sign? Feel of hyperesthesia between 9th and 14th ribs posteriorly. Rigidity and guarding of upper abdominal wall. Presence of vague mass of gallbladder, omentum and exudate. So due to inflammation, there will be a vague, mass. It could be due to all inflammatory cells, the exudates, the necrotic debris, or the gangrenous one. So depending upon the stage of this particular cholecystitis. So gallbladder is enlarged and tense. Green-black discoloration is there. Serosal covering layered by fibrin. So there is suppurative, coagulative exudates. So always remember that exudates always are seen in cases of any inflammation. So gallbladder lumen filled by turbid bile. So in severe cases there is gangrenous cholecystitis. So obviously there is leukocytic infiltration, vascular congestion, necrosis. So what are the differential diagnosis? Perforated peptic ulcer, acute pancreatitis, high retrocecal appendicitis, that's a bit rare one, but is possible, the retrocecal one. Amoebic liver abscess, common one in the right lobe of the liver. So acute pancreatitis, not so common as is cholecystitis. The lobar pneumonia too, okay, the referred pain can be felt there. Investigations, again total count, differential count, blood urine analysis to rule out diabetes mellitus, plain x-ray, very important one, the radiological findings. What are those? To visualize the opaque gallstones, the gallbladder calcifications. 10% of the gallstones are radiopaque and 90% are radiolucent one. See there, 90% are radiolucent. So 10% can be caught easily. What's this Mercedes-Benz sign? The triradiate presence of these calcified areas in gallbladder found on X-rays. That is Mercedes-Benz. Just like that particular sign is visualized in this particular X-rays. The biradiate one, Seagull signs. And ultrasonography, success rate is more than 95%. So more of a radiological diagnosis. Calculus, posterior acoustic shadow, acalculus, inflamed, thickened organs. So this is again the signs how these particular gallstones are expressed here. If it's triradiate, Mercedes-Benz sign, and if it's a biradiate one, so we saw about the Seagull sign. So again the different scans that can be done, HIDA, PIPDA, all these other scans that the patient is subjected to, that is hepatic immunodiestic acid one. So this is basically excreted in biliary tree within 1 hour of IV administrations. CT scan not only detect gallstones but also detects perforation. So supportive one when USG findings are not clear. Treatment conservative 60 to 70%. Admission, aspirations, antispasmodics, antibiotics to treat all the secondary bacterial infections. For maybe it be gram positive or gram negative ones. Early cholecystectomies. So removal of this particular gallbladder, second to seventh day of admission. So there could be complication of inflamed gallbladder. Prior to these, the conditions are all checked or corrected. Emergency cholecystostomy. About 10% of patient needs emergency cholecystostomy. The deciding factors to be considered are high-grade fever, sepsis, shock. So these are all seen in cases of any perforated one, wherein the spillage of bile into the peritoneum into the abdomen leading to sepsis, shock. Acalculous and perforated GB are strong indications. Then prophylactic cholecystectomy, that is electives. So prophylactic one. So it means complete removal of gallbladder with stones and without symptoms. So prophylaxis. So electively without any symptoms. So patient goes to the OPD and gets abdominal scan for some other vague reason, and just it will be caught. The gallstones are caught on the sonography uh, in the process of diagnosing some other disease. So accidental findings. So in such cases, it could be taken as an elective cholecystectomy or the prophylactic one. Chronic cholecystitis, as the name indicates, chronicity, recurrent attacks of cholecystitis. So it becomes fibrosed, non-functioning, contracted, shrunken, and small. So here patients, there could be fatty food intolerance, Murphy's sign positive, diagnosed by ultrasonography again, or oral cholecystography to the functioning of the gallbladder. So there is thickened wall which contains greenish yellow mucoid bile and stones, subepithelial and subserosal fibrosis. So chronicity, obviously any chronic disease there could be in fibrous tissue formation, the scar. Mononuclear cell infiltration, fusion of mucosal folds, outpouching of mucosal epithelium, that is called as Rokitansky-Aschoff sinuses. I have a question for you. So this is nothing but the outpouching of mucosal epithelium. Porcelain gallbladder, what is this? Extensive dystrophic calcification of gallbladder wall, and this is prone for cancer. So this is clinically significant one. Xanthogranulomatous cholecystitis. The gallbladder is shrunken, nodular, and histiocytes are present here, lipids. Then what's hydrops of gallbladder? This is nothing but the atrophic, chronically obstructed gallbladder with serous secretions. So coming to pathology of calculi. So here we see introduction into the gallstones, types of stones, general mechanism of calculi formation, gross study of these particular stones. So a calculus is a stone, a concretion of material, usually mineral salts, that's formed from. So it's formed in an organ or a duct of the body. So urinary and biliary calculi are commonplace, whereas other sites like salivary glands, pancreas, and prostate are less frequently involved. So formation of calculi is known as lithiasis. So basically there are two types, primary and secondary. Primary, metabolic. So this is general calculi formation in your body, not only just gallstones. Calculi form in absence of any local disease, most often due to metabolic abnormality. They may be found by an increase in concentration of crystalloids, decrease in concentration of carrier molecules, the composition of that crystalloids such as cholesterol and cysteine. Secondary, that are formed around a foreign body such as suture material or discombobulated cells or bacteria. So secondary calculi consists predominantly of radio-opaque salts. Always remember this, radio-opaque salts. So these are ultrasonography findings or else sonography friendly stones, you can say. Mechanism. excessive supersaturation of biological fluids with crystallizable substances, presence of nucleation promoting material, lack of crystallization inhibitors. So all these are contributing factors, the mechanism involved here for the formation of a stone. 3 marks question. Macroscopic stone formation, continued crystal growth, epitaxial growth, crystal aggregations. So there could be again elevated levels of the calcium, dietary factors for gallstones. So various dietary elements are also do contribute for formation of gallstones. Well, the exact specificity of that particular diet is still controversial actually. Local bacterial infection can cause pigment stone, uric acid stone. Slow fluid flow rate can cause salivary gland calculus. So in general calculi formation there. So these stones can cause disease by several mechanisms. Irritation by nearby tissues causing pain, swelling and inflammation. Obstruction of an opening or duct interfering with normal flow and disrupting the function of the organ in question. Predisposition to any infections. Now coming to gallstones proper, the cholelithiasis, a 5 marks question or a 3 marks question too. So gallstones afflict 10 to 20% of adult population. The vast majority of gallstones, that is 80%, are silent. So most of them are taken as elective surgery, the prophylactic one. And most individuals remain free of biliary pain or other complications for decades. See, 10 years will be passed, 20 years will be passed, nothing, no symptom. So patient knows he hosts these particular gallstones in his gallbladder. But unless these gallstones obstruct at the neck of this particular gallbladder, they are quite asymptomatic. So patient can live along with the gallstones if it is asymptomatic. Symptomatic gallstones can progress to complications. The racial differences. So again, high incidence found in white females and low in black males. So this is just an incidental findings one. The stats point towards these findings. Less frequent in India than the Western. 7 times more common in North India than the South India. Again, all this, your lifestyle, your dietary, and then even to some extent your susceptibility. Types of these gallstones: the cholesterol stones, the pigment stones, the mixed ones. So pure gallstones of various types. These are the pure gallstones here. Gross findings: the cholesterol stone, white, pigment mulberry shaped one, the calcium carbonate, the very hard stones, the radiopaque ones. Some beautiful stones there. The mixed gallstones, the multifaceted one. So you can see a multifaceted personality can host such multifaceted gallstones with a pinch of humor there. So the combined gallstones, the smooth surfaced one. The cholesterol stones. The cholesterol stones are mixed stones with cholesterol as the main component. That is the 60%. Less than 5% of patients have pure cholesterol stones, which are usually unique and smaller than 0.8 centimeters. So these are again could be ovoidal cholesterol stones. Faceted ones, spherical or mulberry ones, shape. So this is again stones composed largely of cholesterol are radiolucent. Sufficient calcium carbonate is found in 10 to 20% of cholesterol stones to render them radiopaque. So all these different pictures. Now, risk factors for gallstones, the cholesterol stones. Demography. Well, we move on there. Advancing age. So more common in elderly people. Females common, the female gender, especially with oral contraceptions. Pregnancy, multiparity, obesity, metabolic syndrome, rapid weight reduction, So that can also be cause of these gallstones. Some amazing contributing factors there. Gallbladder stasis, inborn disorders of bile acid metabolism, then hyperlipidemia syndromes. The hereditary factors. Much progress has been made recently in identifying susceptibility. So, some susceptibility, some people are very prone. It could be even familial. So, again, there the ATP binding cassette transporters. So, what are these? Genes encoding hepatocyte proteins that transport biliary lipids. So, some genetics behind this story. The ABCG5, ABG2 genes. Pathogenesis. Cholesterol is rendered soluble in bile by aggregation with water-soluble bile salts and water-insoluble lecithins, both of which act as detergents. When cholesterol concentrations exceed the solubilizing capacity of bile, that is supersaturation, cholesterol can no longer remain dispersed and nucleates into solid cholesterol monohydrate crystals. So, cholesterol gallstone formation involves 4 simultaneous conditions. What are those? The bile must be supersaturated, hypomotility of the gallbladder. There is no proper motility. So, it promotes the nucleation, the nidus formation. Cholesterol nucleation is accelerated. Hypersecretion of mucus in the gallbladder traps the nucleated crystals, leading to their aggregation into stones. The supersaturation of bile with cholesterol is the result of hepatocellular hypersecretion of cholesterol. This appears to be a primary defect mediated by abnormal regulation of hepatic mechanisms for delivering cholesterol to bile. So here then the gallbladder hypo. So some blurring of images there. Just a minute. Yeah, hypomotility. So important contributing factor. The muscular stasis appears to result both from intrinsic neuromuscular dysmotility and from diminished muscular responsiveness to cholecystokinin, the hormone secreted by the gut that promotes gallbladder contraction. The relative composition of trace proteins in bile also may be altered such that the balance of anti-nucleating and pro-nucleating proteins shifts in favor of accelerated nucleation of cholesterol crystals. The cholesterol nucleation, important one. The nucleation of cholesterol monohydrate crystals from multilamellar vesicles is crucial step in the process to the formation. See there, the promoters and the inhibitors of this stone formation. Or the promoters, gallbladder mucin, the alpha-1 acid glycoprotein, the immunoglobulins, the aminopeptidase, so lipases there. The inhibitors, aspirin, NSAIDs, apolipoproteins, ursodeoxycholic acid. So even these are the drugs, the medicines that can be given in such patients containing ursodeoxycholic acid, which are the inhibitors, the treatment path. So as a result of these events, supersaturated bile is sequestered in a hypomotile gallbladder under favorable nucleating conditions. The hypersecretion of gallbladder mucus completes the tetralogy as the cholesterol crystals are trapped for sustained periods, enabling their growth into macroscopic concretions. The superimposed conditions exacerbate defective gallbladder emptying and the likelihood of forming cholesterol stones. Prolonged fasting, pregnancy, rapid weight loss, total parenteral nutrition, and spinal cord injury, all these contribute apart from supersaturation there. Then brown pigment gallstones. So the brown pigment stones are completely different from other stones because they are caused by bile stasis and infection. The gram negative one then, E. coli, which produces enzymes such as these, the phospholipases, beta glucuronidase. These enzymes hydrolyze the normal bile components, causing the precipitation of the typical components of brown stones, that is calcium, bilirubinate, and palmitate. The brown stones rarely occur in the gallbladder, but when they do, it is normal in patients older than 70 years with bile stasis history. So the brown stones specifically form in the bile ducts. So when it forms in the bile ducts, it's cause for an acute pain. So you can't take an elective surgery as option. So could be taken as an emergency call there, either in the common bile ducts or within the intrahepatic ducts. Risk factors. So again, chronic hemolytic syndromes, the biliary infection, the gastrointestinal disorders like ileal disease, ileal resection, the cystic fibrosis, pancreatic insufficiency, pathogenesis of these pigment stones. The pigment gallstones are complex mixtures of abnormal insoluble calcium stones of unconjugated bilirubin, remember that, along with inorganic calcium salts. So disorders that are associated with elevated levels of unconjugated bilirubin in cases like hemolytic syndromes, ileal dysfunction, superadded with bacterial contamination of this particular biliary tree increases the risk of formation of pigment stones in this gallbladder. So just a minute, some blurring of the images there. So unconjugated bilirubin is normally a minor component of bile, but it increases when infection of the biliary tract leads to release of microbial beta glucuronidases, which hydrolyze bilirubin glucuronides. Thus, infection of the biliary tract with E. coli, Ascaris lumbricoides, or the liver fluke increases the likelihood of pigment stone formation. So, what's that pigment? Brown pigment stone. So, this is again the features of these particular gallstones. Basically the table that you can put forth in your exam answers, the mixed stones, that is the contributing, what's the percentage there, 80% are of mixed gallstones, the combined 10%, then the pure gallstones could be cholesterol, bile pigment, calcium carbonate, that contributes for 10%. So the brown stones tend to be laminated and soft and may have a soap-like or greasy consistency because of calcium carbonates and phosphates. The brown stones which contain calcium soaps are radiolucent. See there, the multiple brown stones. So this has got every chance. The more smaller the stones, the more riskier, because every chance of these smaller stones to get jammed into that particular bile duct or causing obstruction, leading to cholecystitis, acute emergency. The patient lands up at the surgery OT. Black pigment gallstones. Black pigment gallstones form exclusively within the gallbladder. So the black pigment gallstones are not associated with cholesterol supersaturation. On the contrary, black stones are frequently found in patients with cirrhosis, congenital hemolytic disease. That's important. The black stones, the pigment one. So a lot of hemosiderin being contributed there for the formation of these black stones. Black pigment stones contain oxidized polymers of the calcium salts of unconjugated bilirubin, small amounts of calcium carbonates, calcium phosphates, and mucin glycoproteins, and some cholesterol monohydrate crystals. They can form not only as unique stones but also in patients with previous stones of other types. See the Rokitansky-Aschoff sinuses We also already mentioned about these particular in earlier slides. So these ones, the black stones are small. So they are initially formed there. So approximately 50 to 75% of black stones are radiopaque. So their contours usually speculated and molded. The clinical features, see that 80% remain asymptomatic. So only 20% have pain, have symptoms, some sort of symptoms. So studies have shown that gallbladder stones grow at a rate of approximately 1 mm or 2 mm per year. So very slow pace. So you can say patient friendly. The most rapid growth takes place in the first 2 to 3 years, after which the growth stabilizes. So after the formation of any calcaline nidus, rapid growth around that particular nidus, concentric deposition of the salts, various salts, is rapid in first 2 years. Later on, it completely is decelerated, the pace at which these stones are formed. The biliary pain, which tend to become excruciating and consistent only in 20% of the cases, remember that. Right upper quadrant pain associated with flatulence and discomfort induced by fatty food. So transient blockage of ampulla of Vater, possible cause of acute pancreatitis. So even gallstones can cause pancreatitis. Remember that. The infection, empyema of gallbladder, well-known sequel. Ascending cholangitis complicates obstruction. The complications. Again, the cholecystitis, hydrops, mucocele, cholangitis, obstructive cholecystitis. Gallstone ileus, pancreatitis, perforation, the dangerous one. Once it gets perforated, any organ perforation, be it an appendix, small intestine, or the gallbladder perforation, leads to peritonitis, shock, sepsis. So very catastrophic clinical scenario there. The complications one. Then relation to gallbladder cancer. Gallstones are most important factor associated with cancer, which are present in 90% of cases. However, it should be noted that only 0.5% of patients with gallstones develop cancer after 20 or more years. More propensity in cholesterol types than pigment stones. Porcelain gallbladder is particularly likely to become cancerous. So, Viva question. What is the significance of porcelain gallbladder? This has got relatively more chances of progressing to CA gallbladder. So this coexistence is much lower because of common presence of pyogenic and parasitic infections of the biliary tree in few people. Choledocholithiasis. So majority incidence found in Western countries. 12% of patients with stones in gallbladder. So there is incidence increases with age. They may be small or large, single or multiple. The stones. Primary, brown stones. Secondary, cholesterol type. So migration to cystic duct into the common bile duct. These are classified as secondary common bile duct stones in contrast to primary that forms in the bile ducts. So these stones also could be seen locked up in common bile duct. Treatment, non-surgical and surgical. Non-surgical ones, dissolution therapy, quinodeoxycholic acid, orthodeoxycholic acid given as drugs to reduce its size basically and avoid obstruction. Direct solvent dissolution. Surgical ones, cholecystectomy, laparoscopic cholecystectomies, cholangiographies, laparoscopic common bile duct exploration. Disappearing gallstones. What are these? Refers to rare phenomenon in which gallstones vanish, disappear, possibly due to spontaneous passage via the common bile duct or cholecystoenteric fistula or through spontaneous dissolution. Intramural gallstones, refers to those that are embedded in the wall, possibly via ulcerated mucosa or Ashaf-Rokistansky sinus. Floating gallstones, the name given by radiologists, so this is basically sonographic findings, to those that float in the bile because of density gradient between bile and its contents, which may be induced by fasting. So only disadvantage in fasting people, rather usually the fasting has all beneficial effects. The only disadvantage of fasting is this one, could be a contributing factor for formation of gallstones, the fasting. So gas in gallstones, rarely center of stone may contain radiolucent gas in triradiate or biradiate fissure, and this gives characteristic dark shapes on radiograph. Okay, so this is how these particular signs are developed on sonography, the sonographic findings, the Mercedes Benz sign, Siegel sign. Limibile is revealed on plain X-ray opacity, is the result of gallbladder becoming filled and mixture of calcium carbonate and calcium phosphate, usually consistency of toothpaste. So there is toothpaste consistency of these particular stones. The condition tends to occur when there is gradual obstruction of cystic or common bile ducts. Some few extra points there. Mersey's syndrome, a viva question in your practical examinations. It's a rare complication in which a gallstone becomes impacted in the cystic duct or neck of the gallbladder, causing compression of the common bile duct or common hepatic duct, resulting in obstruction and jaundice. The obstructive jaundice can be caused by direct extrinsic compression by the stone or from fibrous or fibrosis caused by chronic cholecystitis. So a cholecystocholidicol fistula can occur. What is the Saint's triad? Gallstones, diverticulosis of colon, and hiatus hernia. So this is more of a viva question. Sometimes 3 marks too, but very rare. Saint's triad. So we conclude the story on gallbladder with this particular slide. Every block of stone has a statue inside it, and it is the task of the sculpture to discover it. So basically, doctor has to diagnose the pathology or the causative agent, the etiological agent in a patient, and identify that particular stone and treat that particular patient. So always remember, in this case, in gallstones, 20% only come up with the symptoms, sign symptoms, or else 80% of the times they are asymptomatic. So it is just as a accidental finding in a path to diagnose something else. So you order a sonography for something else, and then accidentally you diagnose that the patient is hosting these particular stones in his gallbladder. So it could be elective in such cases, or it could be emergency surgeries, especially in cases of 20% cases where it's acute cholecystitis associated with obstructive gallstones, wherein these are gets the smaller, the smaller stones, the more riskier, because more chances of these smaller stones getting impacted or locked up in the bile duct or the common bile duct or the ampulla of Vater, or can just move out if they are very small enough into the second part of the duodenum, and then contributing for vanishing gallstone category. So we all saw about the normal physiology of gallbladder, then inflammation of the gallbladder, that is acute cholecystitis, chronic cholecystitis, then the stones, to different types of stones, the cholesterol ones or the mixed ones or the vanishing ones, or the depending upon the types, the content, the chemical composition. We saw about the genesis of these particular stones, and medical emergencies, and the porcelain gallbladder more commonly involved with the cancer of this particular gallbladder. And we conclude the session on gallbladder with this particular slide. Myself, Dr. Rajesh Patil, signing off. Meet you again soon in the next class of pathology. Thank you. Take care.